I am. Yep, we're ready. Are you changing the screen or me?
You're doing it.
Okay, perfect. Good afternoon, everyone, and thank you for your patience while I got organized there. We start our day with who I am. I'm Bill Malm. I'm VP of Client Strategies here at VitalWare Health Catalyst. And we start off with a disclaimer. Dusty, it's not changing. So the agenda for today, there we go. The objectives for the agenda and objectives we're going to cover. We have a disclaimer that I've apparently can't switch to at the moment, but it basically talks about that it's to be used for educational purposes. This is not a legal decision in any way, shape, or form. So our objectives is, this has been around for quite some time. And what is a self-administered medication? How we're supposed to bill it. We're going to talk about parts B and D for Medicare, and then the OIG safe harbor ruling on waiver of SAD charges. And this is a real problematic area for pharmacies as well as patient billing and third-party collections groups, because they really don't understand it, and more importantly, your patients don't understand it. Dusty, it's not wanting to change. There, no.
Here, 1 second. Maybe we can see if I can make this a little bit better for you. Do you have the presentation up on your screen here, Bill? You could pay me.
Do I what?
If you have the presentation up on your computer yourself, you could end up sharing that if you'd like, instead of me sharing it and you trying to control it. It might make things a little easier.
I do have a presentation up. Can you see my screen now? Dusty?
I think you're just controlling my screen. Sorry about that.
All right, we'll take it back then. Are you able to do it, Dusty?
I'm going to stop sharing here, Bill.
There you
Sorry
are.
about this, everybody. We're through the technical difficulty to this one. Now, see if
now
we can
I'm
share.
going to share my screen. It says
Yes.
My browser is preventing access to my screen. You going to allow me to share the screen?
You should be able to. You want to try one more time now?
Sorry, guys. Technology and me today are just not getting on with each other. Can you see my screen?
I cannot.
Yeah,
okay.
So
I'll bring it back up, and if you just want to give me a cue when you want to switch slides, I'll run
yeah,
it.
that's it. I'm sorry this is not ideal, but all sorts of technology. Vanessa, thank you. It happens all the time. Yes, it appears to happen quite a bit today. Full moon was last week, so we really can't be having that again. So there we go, Dusty. Do you want to put up full size?
All right, you let me know where you want to go, Bill.
Okay, go to the next one. Okay, so we talked about the objectives. You could click on to the next one. So our agenda is, we're going to go back in time. We're going to go back a decade, and we're talk about what is a self-administered drug. The patient's perception of a SAD drug, the billing perception, and the pharmacy perception are sometimes not the same. We're going to talk about the complexities involved with your charging, and then what is available on facts for Medicare, and then the big question, should I be charging this or shouldn't I? So go ahead and onto the next one. So what does it stand for? In many places, it's a forgotten source of revenue. It is an opportunity to collect revenue to counteract your expenses for medications delivered in the outpatient hospital environment. In other cases, it represents a revenue stream that you may not want. So we're going to have to look at both sides of the coin today. On to the next one, Dusty. So we're going to start with the source authority. Where's this coming from? Who's saying what and where? And it starts right out in the Social Security Act, where Section 2A says that drugs and biologicals which are not self-administered are included as a Medicare benefit. But the self-administered meds are not a benefit. And if you go through this, and it then takes that Social Security Act and it moves it down to the Medicare Benefit Policy Manual. So a lot of times when I work with clients, they say, where in the claims manual does it say this? It's not in the claims manual. It's in the Benefit Policy Manual. The reason being is there is no benefit. And before you can have reimbursement, you have to have a benefit. So you go to Chapter 15, Section 50.2, and that starts the regulation. Dusty, on to the next one. So, as I just said, coverage before reimbursement. You have to reach a benefit category before there's an expectation of reimbursement. Therefore, in the Social Security Act and 42 CFR, there are only 4 benefit categories. The inpatient Part A, Part B, outpatient professional, Part C, Medicare Advantage, and Part D, pharmaceutical benefits. Those are your benefit categories, and the medication has to fall within one of these in order to be considered reimbursable. Since the self-administered drugs are in fact statutorily excluded, there is no expectation of reimbursement from any of these. Now, this is separate reimbursement, and we're going to talk about Part A. They are covered drugs. They're just not represented as a separate reimbursement. So, but they're covered under Part A. On to the next one, Dusty. So, in Part A, it's an inpatient benefit. It's packaged with the DRG. It is covered, but not separately reimbursed. In Part B, only those medications that are not integral to a procedure and are not determined to SAD are covered benefits. So you can have them as covered to an integral to a procedure. It would be covered, but not SAD. And then Part D, it depends on the plan and the formulary. Remember, the service or procedure must be covered before there's an expectation of reimbursement, and they are excluded here. On to the next one. So this is just a restatement of what I've just said repeatedly here. You got to have your benefit before coverage. So let's get on to the next one. So Benefit Policy Manual, Chapter 50, starts with the coverage criteria, and this is screenshot from the manual. Generally, drugs and biologicals are covered only if all of the following are met. So they're covered, but you have to meet all these points. They meet the definition of a drug or biological. Well, self-administered do. They are the type that is not usually self-administered, so therefore they don't. But they do meet the requirements for Incident 2 and medically necessary, so these are not covered because of the second bullet point. Go on, Dusty. The Incident 2 criteria begins in Chapter 50.3, and even under the Incident 2, in order to be covered under Incident 2 provision, it has to be of a form that is not usually self-administered. So when you're looking at coverage, you have 2 distinctly different points that are not covered. The Incident 2 and then the coverage guideline from the prior slide. On to the next. So what is self-administered? And usually when I'm on the phone with the patient, they're like, I was really sick. I couldn't give it to myself. The nurse had to do it for me. Or the hospital wouldn't let me take my own medication and it's costing me a fortune. Why wouldn't you let me take my own medication? Basically, self-administered has nothing to do with an individual Medicare patient. It is taken as a collective group, a universe of all Medicare patients, and whether they as a group can administer the drug by themselves. So there are some criteria for the group. Absent evidence to the contrary, all drugs delivered intravenously are not usually self-administered. Well, they're covered, and they have a benefit package, but they're not self-administered. Absent evidence to the contrary, presume all drugs delivered intramuscularly are not usually self-administered. So those two criteria in the global sense, and there can be some exceptions, in the global sense, they're going to be covered medication. However, those that are subcutaneously are in fact considered self-administered. So then you're going to get into your exclusions, and we'll talk about that in a minute. So based on this criteria, the majority of your oral inhalations, rectal, topical, subcu, intradermal, are in fact self-administered. And the easiest way to do is to go through your formulary, have the pharmacy print out or show you where are these routes of administration, and you can go in and you can itemize them for billing purposes. So on to the next one. Only injectable drugs are eligible for coverage under the Incident 2 benefit. So this is a separate one. Under Incident 2, the injectable drugs are eligible. If there is one or more use for the drug, then Medicare contractor must determine. So here's an example where something with an IV could be denied. The contractor has to decide what is the most prevalent use of that drug. So maybe the use of the drug prevalently is self-administered, but you could, like a Zofran tablet, but you could get it IV, but is the prevalent use the IV? So they're going to have to figure out each of these, which is the more prevalent form, and weigh each indication. And the way they do that is on the next slide. Dusty's having a good time changing my slides for me. Other factors. The MACs are instructed to consider the factors that result in a self-administered exclusions list. So first of all, is the condition acute? If it's acute and short-term use, it's less likely to be a self-administered drug, because if you think about it, 50% of the population on an acute basis that's infrequently administered is going to know how to do it. However, if it's a long-term use that's done frequently, then like insulin, it's going to be SAD. So the frequency and the acuteness of the condition will help determine for the MAC which of these, what exclusions list it's on. So long-term use, that's more frequent, so the patient, 50% of the beneficiary should know how to do this, it's going to be self-administered. However, a short-term acute use, less likely to be self-administered. On to the next one. And remember, the MAC determines this. So it's not up to me in this presentation to determine yes or no. The MAC has an exclusions list. There's also a concept called integral. Now, this is when it is covered, not statutorily excluded, but it is not paid separately. It is part and parcel of the procedure. So certain drugs are so integral to the treatment or procedure that the treatment or procedure absolutely cannot be performed without them safely. Because the drugs are so clearly an integral component, they're packaged as supplies under OPPS, and they're included within the payment. So the question is, are they covered? Yes, they're covered. They're not self-administered, not statutorily excluded. They're covered, but you have no expectation of a separate reimbursement. They're packaged. The facility CDM requires a line for cost accounting. Then this type of covered package service that's integral uses revenue code 250. And we're going to go on to the next page and show you how to do that. So what is an integral supply? And they give you, there's been a whole bunch of it. One is the sedatives administered to a patient while they're in pre-op. If most patients get that, and then they're going to be integral to the procedure, you're not going to get reimbursement. Mydriatic drops before you do a cataract, or some eye drops for your antibiotics. They're all going to be included within the procedure and not separately paid. Barium, you can't do a barium swallow without the barium, or low osmolar contrast provided integral to a diagnostic. They're also going to be integral according to the definition and packaged as a supply. Topical solution for photodynamic therapy and antibiotic ointments such as bacitration on a wound or surgical incision. So these are examples, and certainly not an all-inclusive list. I know CMS has got into some sort of dissertation in the past with these. This is the list. This is not the list. The list is determined by if it's integral to the procedure and if you are providing that to all patients for that procedure. So on to the next slide. All right. Before we go on, I see quite a lot of chats. Dusty, do we need to address some of the chat?
Looks like it's mostly commentary around insulin stuff.
So the insulin on most self-administered exclusions lists is in fact self-administered, and you would end up billing the patient, even if it's given IV for ketoacidosis. And then there are other groups that just don't charge for insulin. Even though you're supposed to reflect your cost as a resource, they don't charge it. So I have seen different MACs behave differently on the topic of insulin. And so I would tell you categorically, they're self-administered. However, the MACs have removed them from many of the exclusions lists, and they consider them to be covered services, but usually as part of a bigger benefit. So you will see the MACs behave differently on that.
So I don't know if you, Kimberly asked an interesting question there too around like IV meds. I don't know if that's.
Well, IV meds, that their predominant method of delivery is not IV and is in fact self-administered. Under that self-administered determination of acuteness and frequency, the MAC can determine if there's multiple different uses for the same drug. I mean, routes of administration. They will have to determine what the most prevalent one is, and once they determine that, it'll either be on or off the exclusions list. So we're not going to be able to do that here.
Sounds good. Just a reminder to the group, if you have questions related to the topics in the webinar, if you can put it in the Q&A panel, that helps keep me and Bill organized quite a bit. But we love the dialogue, so keep it coming. All right, go ahead, Bill.
So the next thing that's caused a big stir with a lot of patients is they said, I didn't know that. And Medicare's response is you absolutely do, and you are responsible for the knowledge because every year you receive a Medicare and You handbook, and it's offered in multiple different languages, hard copy and electronic. And if you are a participant in the Medicare program and actively enrolled in getting benefits, this is your handbook, and it tells you what's covered and what's not covered. Just like if you had commercial insurance with Aetna Cigna, you're going to have your coverage manual. And on a page in that, it specifically says, however, Part B doesn't cover other types of drugs in a hospital outpatient, sometimes called self-administered, or ones you take on your own. What you pay depends on whether you have Medicare drug coverage or other drug coverage, whether your plan covers the drug, and whether the hospital's pharmacy is willing to work. So basically, they're saying right then and there, it may get paid, but we're not guaranteeing it. And that's in the Medicare manual. So the issue here becomes, did the beneficiary read it? I know a lot of people a little bit older than me that are on Medicare, and they're like, what's the handbook? What are you talking about? So it isn't a commonly used item. And then the other people, like my grandfather, used to memorize the pages. So, I mean, you've got all sorts of different opinions here. On to the next one. So how do you let the client know that something's not going to be covered if it's statutorily excluded? Well, under the conditions of, the limitation on liability, Chapter 30, it says that a voluntary ABN may be issued for the purposes of information for a statutorily excluded medication or other service. So basically, payment condition 1 on the following sides appeal. The beneficiary claim for a particular drug is denied because the drug is self-administered, and the beneficiary may appeal the denial because it is a benefit category denial and not a denial on medical necessity, and ABN is not required. So the question I always get is, do I have to give an ABN for self-administered drugs? No, only if you want to. A lot of people use the ABN as a method of informing their patients that they're going to have an expense at the end of this road here. But when it doesn't trigger a financial liability protection, you're not obligated to do it. So Dusty, on to the next one. So if I look at these different payment situations, payment condition 1 is, this was from Administered Federal. This is just old. But items and services are being statutorily excluded from original Medicare. And the liability notices prior to billing are voluntary because they're statutorily. So there's no required Medicare notice because according to Medicare, they've already done it in the Medicare and You handbook. Items and service may be billed as non-covered on the Medicare claims. So go on to the next one, Dusty. And they're always going to be denied. Beneficiaries are liable for these denials unless the providers code their claim to transfer liability to themselves. This is a very big statement. So they're going to be denied unless you decide you're going to make them provider liability. If you make them provider liability for one payer, you must make them provider liability for all payers because you have to charge everyone the same. Doesn't mean you have to collect or bill, but you have to charge everyone the same. So this is the first crossroads we're going to talk about. On to the next one. Why do I want a voluntary? 1, it notifies the patient they're going to receive a statement and be liable for the charges personally. Number 2, it outlines the amounts they may be responsible for. 3, it's a source of education. 4, it decreases that sticker shock when the patient gets the bill. 5, the ABN selection Medicare and You, it references this so the patient feels that it's their facility doing it. So you need to make sure you do this on a Medicare form so that you show that this is not your hospital doing this, this is Medicare. And then use the ABN for the sole purpose of promoting customer satisfaction. That's the biggest use of a voluntary ABN with self-administered drug, is to basically let the patient know, here's what you're going to get a bill for, this is what you're liable for, and these are statutorily excluded by Medicare. Doesn't mean you can't send it to a secondary payer, but they're excluded from Medicare. So next one, Dusty. So to determine the SAD, determine if the medication is oral, topical, inhalation. So the Medicare Exclusion Program Memorandum, which goes way back to 2002, instructs the Medicare carrier or the MAC to model after the guidelines, which are determine the exclusion for Medicare coverage of those drugs, which are usually deemed self-administered, even though they may have been covered under the Incident 2 provision. This is one of those with the IV drug that suddenly is now self-administered. It's covered with Incident 2, but it isn't covered by the MAC's determination of that. And so there are every single MAC, if you go onto their website and put in self-administered exclusion, it's going to list every single exclusion for that region. So, and they're going to differ. So make sure that you're pulling up your MAC for your region. So J and H are not the same. So on to the next one. So here's just an example from Novitas in Louisiana way back in the day, self-administered drugs. It goes through the section it's going to use and the definition, and it goes through how they determine it, and it gives the exclusions list as a following thing. Each one of your MACs will have an exclusions list. On to the next one. You have to determine, first of all, if it's oral, topical, inhalation. So you're going to need the right J code, the right name, and the right NDC. So you're going to have to find that out. So if the J code is, in fact, assigned to an IV drug, and it really was misassigned and it's an oral, then you're going to have a problem. So for example, the J code for one of these two, we're just going to make it up, the calcitonin, okay? Say that that was an oral drug and an injectable. And you put the J code on the oral too, when it really can only be used for the injectable. Miscoding can create an incorrect self-administered med, or vice versa. So on to the next one, Dusty. So you need to look at the exclusions list. They also, on the exclusions list, you may have something that's self-administered, but it is also integral to the procedure. So therefore, you're going to package it. But they have to be on the exclusion and not integral in order to bill them as a self-administered. For that, NUBIC, the National Uniform Billing Committee, has recommended code 637 as the revenue code of choice, and any applicable HCPCS code. Some Medicaids still want 259, but commercial payers follow their contracts. Some want 250, some want 637. So that's a contractual basis. They may or may not follow the Medicare coding guideline for this, but for Medicare, it's 637. On to the next one, Dusty. So how am I going to bill for this? Let's go to the next one. First of all, 250 is used for general pharmacy items. So it has to be provided by a licensed pharmacist. Covered revenue center generally constitutes a package revenue center and usually used for SADs that are integral and function as supplies or are in fact an inpatient. That's going to be 250. 343 is your diagnostic radiopharmaceuticals and their policy package. So that's not a self-administered. It's coming under a different packaging program. And then 637 is the self-administered medications, and that is designed by the National Uniform Billing Committee, which is part of the American Hospital. So when I'm setting up the circumstance of which revenue code, first of all, SAD is not a concept for inpatients. It is a Part B outpatient coverage criteria. So for inpatient, it's going to be 250. And the reason it just gets packaged in with your drugs. For outpatient medications, it's going to be revenue code 637 if it's in fact a self-administered. And then for observation, big flash of alarms there. Observation. When you have patients in observation for 24 to 48 hours, these drug prices can really start piling up. So you're going to want to start that involuntary ABN the voluntary ABN and or some sort of education early on in the observation period. You know already that observation is confusing to patients. You're giving them a moon and all sorts of other things. And this is a whole confusing concept to them. So therefore, this is going to have to be part of that education. And then outpatient but integral, you're going to use the 25X series, meaning it's part and parcel of a bigger procedure. On to the next one, Dusty. So the NDC determines a HCPCS, and this is where I see a lot of self-administered and regular medications get miscoded. The NDC was used for something and then you bought something else, but you kept the same NDC number in your formulary or in your pharmacy, and it's still linking to a HCPCS code, but it isn't the HCPCS code that is really for the drug. And if you look at the NDC number, they talk in the Medicaid programs that the NDC number, and Medicare as well, must be that number that is on the vial that was administered or the package that was administered. And that particular NDC number determines your HCPCS code. And so therefore, if the NDC and the HCPCS is not aligned, you may have overcharges and you're charging for SADs and you shouldn't, or you may lose the charge when you thought it was SAD, but it really isn't. So this NDC drives this whole thing. And the ability to link the NDC to the HCPCS is something very, very, very important. I know our solutions in our pharmacy module and in our chargemaster, we're able to do the NDC to HCPCS as part of a report. So it'll spot that. So on to the next one, Dusty. So here's a lookup just in one of our solutions. We can see the NDC number and then the J code that goes with it. If in fact you had a oral drug that had the same description, but it was oral, it might likely not be appropriate for the J code that's in fact an injection. And you'll see at the top in the fourth column to the left or the second column to the right, it says injection, injection, injection. This is not applicable to your oral versions if one should exist, or your rectal, or your inhalation. If in fact it says injection, it is only for the injectable format. On to the next one. So our HCPCS code required. HCPCS code must be reported with any medication for which a code exists. And that's in the OPPS guidelines, the display copy, and it goes 7210. So that's 2010, but it goes back to 2000. Most SADs are oral, topical, or inhalation, and the majority don't have a HCPCS because they generally did the HCPCS code for those injectable versions. So we would not expect a CPT code. The CPT codes are usually relevant only to your vaccines or your toxoids. And then the HCPCS codes, or the ones that start with a letter, they're usually for medications, but generally for the medications that are injectable in some format. Dusty? So should you bill Part D if they're self-administered for Part B? And the current regulation has been unchanged since the day it started. Facilities are absolutely not required to bill for medications that were provided under Part B if the patient has a Part D as in Delta benefit. It's not the requirement of the facility to do that. However, if you take the extra step and think about the end result to your consumer, you may want to give them all the information they need to be able to collect reimbursement from their Part D as in Delta carrier and formulary should they have coverage for that. So because all these Part Ds have different formularies, you're not going to know. This is why Part B isn't required to do it. However, you do need to give the patient enough information to go ahead and be able to send it on to Part D. So charge masters have to be included at the NDC number because the NDC number is what's going to drive Part D as in Delta. So on to the next one. What do I need to provide if I want the patient to go to Part D? Well, there's a number of things. At a minimum, they need the NPI number of the prescribing physician, just as if it was a prescription. The facility NPI number, the NDC number of the drug that was dispensed and the total units, and other items may be required, and you have to work with your retail to determine that the client receives all the information. So now your charge master has to make sure it has the NDC, it has the HCPCS, and your units dispensed. But now when you give the patient this for their itemized statement for Part D as in Delta, you're going to have the NPI number of the prescribing physician, facility, and what have you. So this becomes an extra challenge, but a lot of hospitals do it because it adds to consumer satisfaction. On to the next one, Dusty. So CMS, way back in the day, it was revised in June of 2020, but it actually dates back to 2010, is how Medicare covers self-administered drugs giving in the outpatient setting. If you go to this publication, I recommend you just give this to outpatients and observation patients that are Medicare. With your MOON, you just give them this. I'm seeing a lot of problems about the screen going black. Dusty, are we having an issue?
Are you able to see my screen still, Bill?
No, I'm seeing the panelists that it goes black. Okay, it looks like most people are seeing it. So sometimes people with Medicare need self-administered drugs while in the hospital that you normally take, and this is right from your Medicare and You. If you get self-administered drugs that aren't covered by Part B in the hospital may bill you for the drug. The plan may cover the drug. So this is a specific PDF that was created for Medicare beneficiaries for the sole purpose of telling them how self-administered drugs will be doing. I like this version versus a hospital version with your logo on it because this has the CMS right at the top, and it's revised and it's publicly available. So therefore, when you're talking to the patient, say, not my ruling. This is a Medicare statutory exclusion ruling. So this is an educational tool. On to the next one. All right, this is the most important thing. Most complaints arise between a disparity between the hospital pricing and that can be obtained from a local retail pharmacy. So if you're going to put $5 per tablet on a Tylenol and they can get a bottle of 50 tabs at the local pharmacy, you're likely to not have a consumer that's very happy. Bacitracin, $10 for a large tube over the counter, but it's $5 for the little packet, and you have to use 4 or 5 packets on the wound. Disparities in pricing between retail and hospital pharmacy, especially with self-administered drugs, is a prevalent cause of the dissatisfaction with these charging practices. And we all know our markup on pharmacy is fairly stiff. And so then you have to think about, okay, what am I going to do with my self-administered? I want to be able to cover my cost, but if I drive the price up and it's so far above the community standard, that's going to become a problem when you try to go bill it. They're like, I could have gotten 50 tablets, or I could have brought my own medication, and then you're going to end up with the white bagging scenario. So this is a key consumer concern that you need to work through when you're dealing with self-administered medications in your facilities. On to the next one, Dusty. Dusty, there you go. So when I've talked to different patient accounting departments, it's usually customer complaints over the charges of drugs that they thought were covered. They're in the hospital, they're in a bed, they think it's covered. They're in the ER, they think it's covered. And in fact, it's not covered for Medicare. Some possibilities include working with the outpatient clinic, CD, and ambulatory to show brochures when they discharge. Again, in the ED, you want to be careful about this. You don't want to start talking about financial responsibility in a patient that hasn't had their EMTALA screening. Use as many documents with the CMS logo as possible to demonstrate it's not the facility but CMS. And this becomes a big problem in the ED and ambulatory surgery areas where you get these $20 Tylenols or Toradol or something like that that's huge. So look at how you're educating the patient. On to the next one. So with all those complexities, there's been this age-old question, do I need to even charge for these things in the first place? Well, Medicare is very clear, you must reflect your costs and resources in some sort of charge, not just the cost report. But the facility originally was told since the beginning, you can't waive the charges. It was an inducement. You were up to civil monetary penalties, and it could represent a compliance risk. So this has been kind of the mainstay theory for a decade. If we go on to the next page, Dusty, the OIG took this on. And this is the document is the alerts and guidance policy, but in 2015, so it's been a while now. And they said, nonetheless, in limited circumstances described in the policy, hospitals will not be subject to OIG administrative sanction if the discount they waive for non-covered drugs, the beneficiary receive an outpatient. Now remember, this only applies to OIG administrative sections. It doesn't necessarily apply to all potential infractions within the Medicare program, but as far as the OIG is concerned, they're not going to create an administrative sanction for this. They know this is difficult, and they know this is something that should have been corrected in the Social Security Act. The policy applies only to the discounts or waivers of amounts Medicare beneficiaries owe for self-administered and received for ingestion or administration in the outpatient setting. So outpatient Medicare, only the discount or waiver. Here's another big clincher. Hospitals must uniformly apply their policies regarding discounts or waivers on non-covered drugs. Uniformly doesn't mean just within Medicare. It uniformly means you're charging all patients. So if you're going to waive these for Medicare, you cannot do cost shifting. So you're going to have to waive them for the other payers as well. And it says here, example, without regard to benefit, diagnosis, or type of treatment. The hospital must not market or advertise these discounts, because then it does become an incentive. At that point, it leaves the administrative sanction thing and once again leaves this little safe harbor, and you're back to the problem. Hospitals must not claim the discounted or waived amount as bad debt or otherwise shift the burden of these costs to Medicare or Medicaid, other payers, or individuals. So, therefore, if you decide to waive it, you've waived it. That it's going to be a cost of doing business. And they said, nothing in this policy requires hospitals to discount or waive the amount. So they're saying, we're not requiring you to waive it, but should you decide to waiver it, we're not going to do an administrative sanction. So I think that that came as a relief to many, but it also became a source of consternation for many in finance. They're like, I really want to start waiving all my self-administered drugs. Some of these are expensive. So you have to look at that, you know, what's the best? You can't pick and choose which drug you're going to waive. It's either all or none. Keep going, Dusty. So how do I put this on? Okay, if I'm going to do this, I can say I can use the GY modifier to indicate this is a statutory exclusion. Meaning if a voluntary ABN, then I want to see the GX. So you're going to have GY and GX. Voluntary ABN provided, GY modifier. Placing this modifier on the charge line, the patient becomes liable for the SAD. Facilities will differ on whether to hard code these or not. I have seen facilities do a GY and a GZ as in Z, meaning that they are not only a statutory exclusion, but I'm going to make it a provider liability. Meaning I'm going to shift the cost back to us. I'm not going to put it on the cost report. I'm just going to, this is the cost of doing business. And it is not an allowable cost on your cost report. On to the next one, Dusty. The GY, GX, and GZ is not required if you're sending in a wholly non-covered claim. That was only required if it's on a covered claim. You're going to have to use the modifiers, put the amount in the non-covered column. On a wholly non-covered claim, none of this is required. Just go ahead and code it with the HCPCS code based on the payer. On to the next one. So I get this question. Can I use J3490 unspecified? No, you may not. Self-administered drugs are non-covered, and therefore you must use alpha 9270. That must be on the claim. So if you're going to use a GY or GZ or GX, you must have for the HCPCS code in the non-covered column the A9270. So that's the HCPCS code you need to use. And it includes, it helps exclude the statutorily excluded item. In most cases, people are preferring to just bill it as a non-covered, totally non-covered claim with the A9270. Next one. Here's an example, old. This is actually from Empire back in the day that became National Government Services on how to use a GY modifier for statutory exclusions. Again, these are on wholly covered claims. This is, there's no advanced beneficiary, they're excluded. And again, I see GZ as in Z quite a bit, whereas provider liability. On to the next one, Dusty. So the GX is only when you do a voluntary ABN. So you just need the GY to show it's statutorily excluded. Once you have the GY, there's no obligation under the limitation on liability to provide an ABN. But should you provide a voluntary ABN, the GX should be there, which indicates to Medicare that you have also given the patient knowledge that this is not going to be covered. And it works quite a bit if they go to try to overcome the denial with Medicare. You say, you know, I did a GX. Next. So how do you build your CDM for the SADs? On to the next one. You need to go through the formulary by route of administration, and after you've done your route of administration, go through your Medicare exclusions list for your region. Anything that is integral, mydriatic drops, vasotrace, and things like that, they go into 250. No problem, done and dusted. Same with the radiopharms. However, those that are identified as self-administered need to be placed in the 250 if in fact it's inpatient. So how do you set up your CDM? You set it up based on financial class. If it is outpatient, your chargemaster should say 637. For your inpatient chargemaster, it should say 250. Only those items offered to outpatient would be 637. And this, I get all these questions all the time about 340B. This is not a relevant point. 340B and self-administered drug are completely separate and distinct topics. You need to assign the NDC number and then go ahead and figure out what the J code is if one exists. If one doesn't exist, then the A9270. Next one. So now you've got your route of administration by the pharmacist. You're going to take your exclusions list. You're going to add that to it. And you need to work with the retail pharmacy to determine what requirements, if you have patients on Part D and you choose to, but you are not required to, choose to bill Part D through a retail process, maybe you have a retail pharmacy, what is required for that? Most people just give the information on like a statement. Then the patient sends it into Part D. On to the next one, Dusty. CDM analyst. You need to make sure that the NDC is present, it's current, and it's correct, and the HCPCS code actually maps to it. If in fact you're going to go ahead and put the GY modifier on it for statutorily excluded, you may put the A9270 in the CDM with the GY, and it'll be hard-coded. Otherwise, it would have to be soft-coded, which represents some chance for disparity when you're actually charging. There needs to be a policy and procedure on your self-administered drugs to include how you're going to bill them, how you're going to educate the patient, and how you're going to collect. On to the next one. Billing office. They need to be aware of how the patient's been educated. You need to write a script for them so that they know when somebody calls with a complaint how to best describe this. Just telling the patient Medicare doesn't pay for this is probably not going to go over well, and you don't want to leave them with a bad taste in your mouth. And again, CFO and compliance is going to be your last step in this game. On to the next one. So here's just an example on how you would build this. You've got your mydriatic drops, that's going to be 250. You've got an oral tablet, that's 637. And then down on the bottom, you've got the riboflavin oral per dose, and that's hard-coded. So these are just different examples on how to code it. The A9270 is used when no other HCPCS code exists. All right, Dusty? Support strategies. So I like this one with the keys because that's probably the moving pieces in this. The beneficiary knowledge is key to the success. Creating pricing that's consistent with your end objective, which is basically cover your costs. Produce informational packets. Use the CMS logo. Present informational this is, I can't type here. Informational information. I don't even know what that is. Early in the episode of care. Present your information early in the episode of care. And remember, the last thing they're going to remember is you provided exceptional care, but you left them with this huge bill that they had to pay. So that is a big statement right there. I remember I had a thoracotomy. I had part of my lung taken out. And I remember they gave me great care. You know what else I remember? They charged me $169 for 3 Coca-Colas. That didn't leave my mind, and that's 20 years ago. So, I mean, this type of bad taste, you will remember. On to the next one. Customer support begins with education. It really doesn't work if you try to pull this off after the fact. You want to be able, you educate them early, you provide printed materials. Because most patients are all stressed out in the ER or the clinic or whatever, and they'll go home, and if they read the documents, discharge stuff, and follow-up stuff at all, this will be there for them to read. Most Medicare beneficiaries tend to read the materials. It's the younger group, or they just kind of put them aside, and you know, insurance will cover what they're going to cover. This is very difficult when you're in the ED and ambulatory surgery units, so you want to put special effort into that. On to the next one. Emergency. Give it before discharge, but after EMTALA. You do not want to slow down that EMTALA screening for any financial reasons whatsoever. Get the EMTALA, then move on with this. Copies of the Medicare document is considered an essential element of discharge. So many people print that off on all their Medicare patients just automatically in the discharge instruction. Nurses just have to be trained to explain what it is, not know the ins and outs, and you should provide a hot number on who can where they can call for more information. I usually like to recommend the Medicare number and not your hospital billing office, otherwise they're going to get flooded with concerns that really are Medicare. Clinic services, exactly the same as the ED. Do it at, but in the clinic you could do it at time of registration. On to the next one, Dusty. Anesthesia. This is a kind of a dicey one. You can provide this in pre-op clearance, but then the patients kind of get a little nervous that they're going to have these self-administered drugs, the oral agents that they may get, insulin provided, all of that. So most people do not give it in pre-op clearance. They have this discussion at time of discharge, and also how they could go about Part D. I know people that do it in pre-op clearance, but it generally creates angst before a surgery that they're already nervous about, so it may not be ideal at that point. On to the next one. Observation. This is going to be a high number of complaints. And so I have seen some of your more sophisticated integrated delivery set. They actually have a TV show on it, like a 10-minute spot that plays when you go into the room on, you know, what a self-administered is, what their policy is, what they're going to bill and not bill, if in fact they bill at all. So they educate, they give the documentation out when the patient hits the floor. With the Moon, they tend to give this out at the same time. Nursing is poorly informed on the billing differences between in and outpatient, so I usually have who's ever going to give them the Moon form give them this at the same time. On to the next one. So the goal here is to maximize the education in as many outlets and methodologies as possible. Provide evidence this is not a hospital decision, but Medicare's. Give published materials with logos on them if possible, and provide itemized billing data that they can use for Part D if that's possible within your institution. On to the next one, Dusty. Summary. We're going to get done just in time. These are all defined in the Medicare Benefit Policy Manual and within your MAC's website for exclusions list. The policy manual takes the 30,000 foot view and says everything that is and isn't, and then by route of administration, then your MAC determines if an acute or frequency applies to it, and it goes on to the exclusions list. And notify beneficiaries in advance they're not covered through the Medicare and U. They've created guidance on how to decide to waive or not waive under that document on the policy for the OIG. Most facilities are making sure their pricing is similar to retail pharmacy, so you don't have that disparity of the $40 Keflex when you can get a whole bottle for that at your retail. Many commercials will package them into the case rate. So while you bill them as 637s, the commercial will have a contractual requirement that at the time of billing, you go ahead and you put them into 250, which goes into the case rate. But remember, you can't bill the commercials if you've decided to waive the Medicares. It's all or none. You got to treat everyone the same in your charging practices. You have to charge all patients the same, and we talked about that. And then the education of the patient can reduce the surprise. Interestingly enough, 10 years after this all started, and Congress just never got around to fixing this, which probably should have, and it never came under the Affordable Care Act. We thought that this might get fixed along with the 3-day stay for long-term care. We thought that these things would get fixed, but they still are outstanding and still create operational concerns for your facility. Dusty?
Awesome. Thanks, Bill. And thanks everybody for being patient with us as we went through this technology.
I have 81 chats. What am I meant to do with this?
Oh, don't worry about the chats. So the chats, there was just some conversation about could they see the screen or not at one point. But we do have a few questions in the Q&A panel. So we can
go through it now. GZ, generally they're not considered allowable costs because they were excluded from your from benefits. You had the opportunity to collect, and you may not change the waiver of co-pay deductibles into bad debt or costs for the facility. So I would not say that they are on your cost report. I couldn't get Zoom. Okay. Yes, you get AAPC, I think. Lots on our technology today, Dusty.
Hey, Bill, let's jump to the Q&A panel, actually, instead of the chat. That's where we got some organized questions there. And yeah, just a quick reminder to everybody, if you want to, while Bill pulls that up, you will get an AAPC, a HEMA CEU. We do email that out along with the deck here that you can download, the presentation. You can also find all this stuff at vitalware.com/webinars. We usually post the deck right before the webinar starts as well if you want to print that out. It's a great place to be. Otherwise, Bill, you want to read through these questions and see how many we can answer?
So the first one at the top is, how do the self-administered rule change if at all? The rules don't change, the drugs change. So different MACs will take things on and off the exclusions list. So that will change. So you want to keep your MAC exclusions list current. Robin, distinction between intravenous and the same drug and sub-Q or self-administered route be shown the difference in the HCPCS. Yes, Robin, you're absolutely right. If in fact it was shown as sub-Q or in the HCPCS definition, then yeah, they're going to go by that. But we're talking about some drugs where there is a HCPCS code for, in fact, the intravenous or intramuscular, but there is not a code for the oral. Zofran would be an example. Where there isn't one for the oral or the self-administered route, but you inadvertently put the J code on it for the injectable. So yes, there usually is that description. Joan, we code the ER in immediate care if a patient comes in and has a blood sugar of 300, saying the charge. Yes, that's exactly what I'm saying. These are self-administered. It is not relative to the patient situation. It is relative to the Medicare population as a whole. And some MACs will allow you to do the actual insulin. I know that the inhalers, though, are considered self-administered. Is Lovenox considered an SID? On most MAC websites it is, but you have to check your MAC's websites. It's not always going to be. Not dispensed by a pharmacist and administered by an RN, documented in a very expensive. I don't understand what that means. I don't know what, Linda, I think we need you to clarify that a little, if you would. Ellen, if the med is HCPCS code, can you have it and add the GY and move to non-covered, or you keep the same HCPCS code, but you move it to GY. So you add GY onto the HCPCS code. The A9270 is the HCPCS code of last resort. I think you mentioned that facility waives SAD, it's not covered cost in Medicare. I believe that to be true the last time I checked, because you had the opportunity to make that an allowable cost by billing the patient, and you choose based on your standard to take it back off and make it provider liability, you cannot pass that on as an allowable cost because you have the opportunity to collect your reimbursement up front. There are many oral chemos these days. How do I determine 636? So you're basically going to have to look at the J code and then your exclusions list. A lot of the oral chemos, in fact, are considered self-administered, and you're going to want to work with that actual drug manufacturer to see what discounts you can get for the patients. Pediatric population. Is self-administered changed? No, it is not, because I don't know many pediatric populations that have Medicare, but if you have an SSI patient that's on Social Security and getting Medicare, then it would cover for self-administered, but as a general rule, pediatric doesn't cover Medicare, and you don't have this problem. Have you heard of route administration modifier J and JB? I have, but I don't know them top of head right now, Christine. I would have to go back and research it, but these are the ones that we need now. Okay, I'm new to this. This means ops patient can bring their home meds and deny accepting them to facility during the status to avoid. Yes, that's absolutely right. They can ask for a prescription and go to their retail. So they absolutely can refuse that if they know it's going to be self-administered and you're going to treat it as that. Most facilities will send their home meds through a retail pharmacy so that they actually the prescription goes to the retail and the retail dispenses it. So the only one I just don't know, Christine, is the JA and JB.
Perfect. Thanks, Bill. I know we're a little over time. Again, thanks everybody for joining us, and thanks for helping in the chat and everywhere. I like to help out more there, but just I had to run the slides today. I couldn't do that. So thanks for helping each other out. We have a great community. We do have a couple more webinars coming up this month, so check out our webinars page, and if you need to download this deck, that is there as well. Thanks again, everybody, and we will hopefully talk to you all soon.
Have a great afternoon, everyone. Bye-bye.